Welcome to the presentation of Fit and Strong, a tertiary prevention program for older adults. This presentation will outline a DNP-led interdisciplinary plan for implementing a Fit and Strong program for older adults within a local community. Fit and Strong is a tertiary prevention program designed to decrease the disability often caused by osteoarthritis in older adults. 14.1% of America's total population are elderly. Elderly is defined as those aged 65 or older. Statistics show that there will be approximately 98 million elderly people in the United States by 2030. In Alabama, 15.39% of our population is elderly. The average lifespan of Americans has increased dramatically in this century. In the early 1900s, life expectancy was 47 years. This had risen to 68 years by 1950. By 1991, life expectancy for women was at 79 years and for men 72 years. On average, one can expect to live for 17 more years after they reach age 65. The current growth of the elderly population is largely due to the aging baby boomer generation. In 2030, when the last of the baby boomers turn 65, 1 of every 5 Americans, or about 72 million people, will be an older adult. Chronic disease and degenerative illnesses have replaced acute diseases as the leading causes of death and disability in older adults. More than a quarter of all Americans and 2 out of every 3 older Americans have multiple chronic or degenerative conditions, and treatment for this population accounts for 66% of the country's healthcare budget. Arthritis is the most common cause of disability among U.S. adults, and osteoarthritis is the most common type of arthritis. Data from 2007 to 2009 show that 1 in 5, or 50 million adults, reported diagnosed arthritis, and 1 in 9 suffered from activity limitations of the disease. It is projected the number of adults with arthritis will rise to 67 million by 2030. People with symptomatic OA are 3 times more likely to have difficulty walking and transferring compared to those without OA. The symptoms of OA can lead to physical limitations. The 3 most frequently found functional limitations are bending or stooping, standing, and walking. In 2006 and 7, there were roughly 12.3 million ambulatory care visits and 85,000 emergency department visits associated with OA. In 2009, there were 921,000 hospitalizations with a mean cost per stay of $45,443. A U.S. burden of disease study estimated OA accounted for 6.3% of all years of life lost due to disability. OA is the most common joint disorder in the world and the 3rd most common diagnosis in the elderly. It is one of the most prevalent sources of pain and disability in this group. The prevalence of OA increases with each decade of life, from 33% among those 60 to 70 years of age to 43.7% among those over 80. Non-steroidal anti-inflammatory drugs have traditionally been used to treat OA pain. These drugs, however, cause many toxicities. Acetaminophen is recommended as the preferred initial therapy. Several other topical, oral, and intra-articular agents are now available for treatment, but are limited by efficacy and side effect profiles. Many non-pharmacologic approaches are available but underused. In the elderly, options like exercise, weight loss, physical therapy, bracing, and orthotics should be considered first to minimize adverse medication effects. The American College of Rheumatology recommends beginning treatment with strategies such as self-management programs, social support, weight loss, and appropriate footwear. Prolonged inactivity results in deconditioned muscles and articular stiffness, which worsens the symptoms of OA. Targeted physical therapy and aerobic exercise can lessen these symptoms. Physical therapy has become a mainstay of OA treatment because of its safety and positive impact on pain and function. The FAST trial demonstrated that debilitated adults greater than 60 years of age with knee OA had modest improvements in pain, function, and disability when enrolled in either resistance or aerobic exercise programs. Exercise improves well-being and preserves function, and therefore is highly recommended in older adults that can comply safely. Physical activity is consistently recommended for older adults, and its effectiveness for pain reduction and physical function improvement has been well established. Quick, Foster, Thomas, and Holder conducted a large systematic review to investigate whether long-term physical activity is safe for older adults. Based on analysis of evidence from 49 studies, This group concluded that long-term therapeutic exercise lasting 3 to 30 months is safe for most older adults. Attitudes and beliefs about exercise are important personal factors in explaining why physical activity varies between individuals. Quick and Company conducted a secondary analysis of a randomized controlled trial to evaluate how the attitudes and beliefs of the subjects affected physical exercise levels. They concluded that higher efficacy for exercise and more positive outcome expectations were associated with current and future physical activity levels in older adults with knee pain due to OA. Evidence-based recommendations have the potential to improve the quality of health care. Translating evidence-based recommendations into practice is challenging, and improvement in quality of care must be measured. Hagen and Company conducted a systematic review using designated quality indicators to measure the quality of care for people with OA. Their review found that less than 40% of osteoarthritis patients were offered education and/or self-management or had received recommendation for exercises. They concluded that there is room for improvement in community-based OA care. Osteoarthritis is under-recognized by health care providers and by the patients who suffer with it. As the largest occupational group in healthcare delivery, nurses can be a force in changing how OA is perceived and managed. Routinely asking all adults about joint symptoms can help identify patients who suffer from arthritis. Identification will allow the provider the opportunity to discuss how physical activity decreases pain, improves function, and boosts mood. Fit and Strong is a community-based physical activity program licensed by the University of Illinois in Chicago. It is an 8-week physical activity, behavior change, and fall prevention program geared to older adults with osteoarthritis. The program was developed to assist older adults with osteoarthritis to improve mobility and maintain independent functioning. The program combines physical activity and behavioral health education. Fit and Strong classes meet 3 times per week for 8 weeks. The classes consist of exercises that focus on flexibility, aerobic training, strength or resistance training, balance, health education and self-management for sustained behavior change, group discussion, and individualized health plans for post-class maintenance. Before the program ends, instructors negotiate exercise adherence contracts with participants and emphasize a lifestyle which includes 3 self-directed 1-hour exercise sessions per week. Fit and Strong classes were originally only taught by physical therapists. However, research has found that similar outcomes can be achieved using certified exercise instructors. Seymour and Company conducted a study that compared the results of 2 groups of patients utilizing the Fit and Strong program under different instructor types. No significant differences by group on outcomes at 8 weeks or 6 months were found. Participants completing this program can expect increased confidence in their ability to exercise safely with arthritis, increased participation in exercise, increased lower extremity strength and mobility, decreased lower extremity stiffness, and decreased anxiety and depression. Research has shown these results are likely to be sustained up to 18 months after completing the class. Further research shows that additional measures may be employed to bolster maintenance of physical activity. Hughes and Company conducted a comparative effectiveness trial comparing the impact of negotiated versus mainstream follow-up with telephone reinforcement on maintenance of physical activity after Fit and Strong ended. They concluded that the study provided strong evidence that the negotiated follow-up incorporated in the current version of Fit and Strong, when coupled with telephone reinforcement, is effective in maintaining initial 2-month physical activity gains out to 18 months. Primary prevention refers to the process of altering susceptibility or reducing exposure of susceptible individuals and includes a general health promotion and specific measures designed to prevent disease prior to a person getting disease. An example would be immunizations. Secondary prevention is the early detection and prompt treatment of a disease at the earliest possible stage. The goals of secondary prevention are to either identify and cure a disease at a very early stage or slow its progression to prevent complications and limit disability. An example would be a pap smear. Tertiary prevention strategies are implemented during the middle or late stages of disease and refer to measures taken to alleviate disability and restore functioning. If permanent changes from disease have already taken place, the prevention strategy is designed to help people lead a productive and satisfying life by maximizing remaining capabilities. Fit and Strong is an example of a tertiary prevention strategy. Establishment of a DNP-led Fit and Strong program within a community will require an interdisciplinary team consisting of the DNP, physical therapist, certified exercise instructors, community media, and consumer consultants. The DNP will serve as the director of the program. Physical therapists and certified exercise instructors will evaluate candidates for the program, provide instruction, and ensure safety of participants. Community consultants will provide valuable input and support for the DNP for integrating the program into the community. Media consultants will promote the program to the community through radio, written, or technological sources. Consumer consultants will be the link to the participants of the program. Their insight into attitudes and beliefs of the community will allow the DNP to determine the most appropriate way to integrate the program into the community's current culture. The purpose of the interdisciplinary team is multifaceted. The team will provide education about the Fit and Strong program. They will discourage participation in the program, which will enable the community to decrease disability and improve health. The interdisciplinary team will also assist the DNP with securing funding for the program and locating a safe and convenient place within the community to conduct classes. The DNP, as program director, will have multiple responsibilities. She will set goals for the program and develop a timeline for accomplishment of such goals. The DNP will recruit qualified instructors for the classes and personnel for the follow-up required to assess outcomes. The DNP will develop relationships with media, community, and consumer consultants to help integrate the program into the community. The DNP will develop appropriate policies and procedures and secure funding and other necessary materials needed for the program. The DNP also assumes responsibility for resource utilization within the community. To successfully accomplish this role, the DNP will have to master competencies in all three areas of leadership. Adaptability is the openness to influence or flexibility to acknowledge and consider ideals from others that may be different than your own. Initiative or self-motivation is also required. The DNP must be focused and self-disciplined to accomplish the required task. The DNP must communicate confidence and steadiness during difficult times and adapt easily to new situations. The DNP must be able to communicate effectively and build working relationships with coworkers and external parties. She should offer constructive feedback and encouragement and manage any conflicts in a decisive and fair manner. The DNP should have a solid understanding of the products and services offered, how the various parts of the organization fit together, and understand the financial aspects of the business. The DNP should use effective strategies to facilitate change and overcome resistance by accepting the change as positive, adapting plans as necessary, and leading by example. The DNP should make rational decisions quickly, and action on those decisions should follow promptly. As director, the DNP will be responsible for evaluating the success of the program. Data from follow-up surveys should be organized and recorded at predetermined intervals to assess patient maintenance of skills learned. Perception of effectiveness of the program should be assessed through survey of community and consumer leaders, and the interdisciplinary team satisfaction should be evaluated. Recommendations for improvement should be solicited and considered. In conclusion, the elderly population in our nation will continue to grow over the next 20 years. Preventing or limiting disability associated with osteoarthritis will be beneficial for both the patients and the healthcare industry as a whole. Tertiary prevention programs such as Fit and Strong may be implemented by DNP leaders to improve community health of this population. DNPs must master multiple competencies to direct successful programs. Thank you for participating in this presentation of Fit and Strong, a tertiary prevention strategy for older adults with osteoarthritis.